Good morning. Can you hear me okay in the back, in the front? Great. And I would also welcome you and thank you so much for being here this morning. I'm very excited to have very distinguished panelists this morning to talk about this very important public health problem. Let me just very briefly introduce who we're going to have talking to us this morning. We're going to be led off by Tracy Green, who is a researcher and Deputy Director of the Boston Medical Center Injury Prevention Center. We also have Rebecca Boss, who is with the Department of Behavioral Health Care, Developmental Disabilities, and Hospitals.
I didn't understand.
We also have Representative Robert Craven from North Kingstown, who knows a bit about this issue also and has submitted some legislation on this topic. And then we also have Erin McDonough from the Rhode Island Medical Reserve Corps. I'm sorry to say that Deputy Sheriff Chris Riley was unable to be here this morning because a death in the family of one of the fellow law enforcement officers. So I'm sad about that, but I'm very excited for the panel that we do have. Oops, I of course forgot my little things there. Great, fabulous. So the other thing that we're going to do besides our panel discussion this morning is we're announcing the release of our brief Drug Overdoses Deaths Continue. And this is being released just this morning. As we know, the issue of drug overdoses in Rhode Island has continued to be an extremely high public health problem in Rhode Island. But this morning, we're talking about not just the problem, we're talking about solutions. We're talking about some of the policies and programs that have been put in place to help alleviate this problem.
So in 2013, my medical director, Dr. Fritz Bohr, kept saying to me, overdose, it's a public health emergency. We're not hearing about it, but we need to get involved. So in 2014, we won a grant to start the naloxone and overdose prevention education program, or NOPE-RI. And the idea was, with NOPE, was that I was going to train my volunteers to go out into the community and provide training on how to recognize, prevent, and respond to opiate overdoses with the use of naloxone, Narcan, or without naloxone, Narcan. We focus primarily on first responders, being police departments. We started with the state police in 2014. That moved on to the Capitol and Sheriff's Department, and then we did some municipal police academy trainings across the state. We trained over 1,600 people last year alone on how to properly prevent, respond to, recognize opiate overdoses with naloxone or without. Currently, there's about 15 municipal police departments that are carrying naloxone, as well as your state police, Capitol Police, and sheriffs do currently carry it. So we provided training to those people. Naloxone is very safe. There's not a lot of adverse effects, so it's very simple to kind of teach non-medical health personnel how to recognize and respond to an opiate overdose. It's a respiratory issue. You can provide rescue breathing if you do not have naloxone while you call 911. It's something that can be reversed with naloxone. Naloxone recognizes the drug, the opiate, in the brain receptor and goes and turns it off, if you will, and allows the individual to start breathing on their own. Again, a very little effect. It's one of the most widely used drugs on ambulances, as you'll see. A lot of ambulances will roll up to a scene and actually administer prior to diagnose. They'll administer and then assess based on the scene if the person is not breathing, because naloxone will push the opiate off and allow the individual to start breathing again. So we thought that would be a way to put a tool in the first responders' hands to allow them to actually help. If police are the first on the scene to a drug overdose, they should have that tool. So I'm here to kind of talk about that movement that we made in Rhode Island to increase access to naloxone. So thank you.
Am I next?
I think you are.
Okay. So my name is Rebecca Boss, and I am the Deputy Director at the Department of Behavioral Health Care, Developmental Disabilities, and Hospitals, and overseeing the state's substance abuse treatment and prevention system. We really see overdose as one of our primary concerns that we address on a daily basis, and it really relies on a lot of collaboration with our sister departments, primarily Department of Health, that we've done a lot of work with And that has culminated in the Governor's Overdose Task Force, which is chaired by both of our directors, so the Director of Department of Health and the Director of BHDDH chair a monthly task force on overdose. And in our department, we really view overdose, the approach to overdose as a three-pronged approach. So the first is prevention. We're responsible for substance abuse prevention, and the best way to avoid overdose deaths is to have people not use opioids in the first place or abuse them. And so we, for years, have contracted with community task forces to address preventing substance abuse in our communities. The focus, for the most part, has been on marijuana and alcohol, so our job has been to really work with those task forces to say, okay, we need to take a look at prescription opiates with kids. I mean, for the most part, that's where they start, is with the prescription drugs. And take a look at where the abuse of prescription drugs is happening, and where it's happening may surprise a lot of folks because it's not where you think it might be. There's a lot of use of prescription drug abuse by kids in the suburbs, in Rhode Island and in the more rural areas. So we need to work with them on that. We need to work with health, the media campaigns that Tracy showed. We need to get the word out there. We've sponsored forums. We've had media events. We've had discussions in the newspaper with journalists to make sure that people are educated about the risks of opioids and the risk of overdose. And then one of the other things that we've done is require the use of the prescription drug monitoring program in all of our BHDDH licensed opioid treatment programs. So prior to admission, these docs need to look at the PDMP to see what people are on. And then throughout treatment, they need to be rechecking to make sure that they're aware of any new prescriptions that patients may not have told them about. And then finally, in prevention, probably not finally, there's probably a lot of more things that we're doing I'm not thinking of, but we have a SBIRT training on June 6th. So screening, brief intervention, and referral to treatment is a national model to address, to recognize early risk of substance use disorders. It has primarily focused on alcohol, but this training is going to primarily focus on opioids and the risk of opioid use with individuals with chronic pain and management of chronic pain and the risk of opioid abuse. So if you can put it on your calendars for June 6th, I'd be happy to get the information to Allison and she can send it out to you. Dr. Paul Seal is coming here. It's a model that's being sponsored by the federal government in terms of recognizing the risks of opioids in patients in primary medical care settings. The next prong we look at is intervention. How do you intervene in an overdose? Really, it's about naloxone. So how do we get naloxone out there to the patients that are most at risk? And we have done a few things at BHDDH. We revised our regulations and promulgated regulations that every individual that works in one of our licensed facilities needs to be trained on the administration of naloxone. So in our regulations, there's a requirement that if you work at the Providence Center, then you are trained in naloxone administration, you're trained in overdose. And we require that same training for individual clients that are at risk. So if somebody has a history of opioid dependence, we ask that they be trained in overdose, given education, and trained on the use of naloxone. And then finally, we required that inpatient facilities with someone who has a history of opioid dependence offer naloxone to the individual at discharge. We know that individuals are most at risk when they're leaving an inpatient facility, when their tolerance in their system has gone down to zero. If they go out and use again, there's a significant risk of of overdose. And so having naloxone on hand, offering it to a loved one, when somebody's leaving a residential or a detoxification facility makes a lot of sense. So not only did we require that, but we purchased kits. So we sent out 500 kits to our residential treatment providers and detoxification centers so that if an individual couldn't access naloxone through their insurance, they were able to access a naloxone kit on the way out the door if they wanted it. Nobody was making anyone take it, but if they wanted to have access to that kit, they would have it. We found that our providers were pretty good at getting naloxone through other sources. So many of our kits were not going out the door. So therefore we took about 250 kits and gave them to the Department of Corrections, which is the other place where people leave and are at significant risk for overdose because their tolerance is nothing and they go out and use and then they overdose. So we found that Department of Corrections was a place where we really wanted to see people have access to naloxone or family members give access to naloxone. The sustainability is the issue, and we need to look at, okay, 250 kits aren't going to go far, and they could call and schedule an immediate assessment at this program, which is located in Warwick. Can't get more central in Rhode Island than Warwick. And they would see the person within a day, 2 days, or if the physician felt uncomfortable and was really concerned about the welfare of the individual, offered to come to the physician's office to conduct an assessment on site. That's been going on now for about a year, and I don't know, 12 people have used it? 12 people have used it. No one's used it. So when people say that treatment's not available or I can't get somebody an assessment, I don't know what to say to that, but there is this program that's been available and significantly underutilized. And then finally, probably one of the most successful programs we've had come out of the overdose epidemic has been bringing recovery coaches into the emergency departments with individuals who have survived an overdose. So I remember sitting in a meeting somewhere with Tracy somewhere, and one of the doctors from, I think it was Miriam Hospital, was there, and we were talking about overdose survivors, and I said, well, what do you do with these people? He said, well, they sit there and you observe them for 4 hours. And I said, what happens in that 4 hours? And there really wasn't a whole lot that happened in that 4 hours. I said, gee, wouldn't that be a great time to have somebody come in and meet with this person and see if they could, initially I thought treatment provider, but then that wasn't going to work. So I was like, what about a recovery coach? Somebody who's in recovery, somebody that can meet with an individual, offer hope, offer connection to resources. So we started it, and Anchor Recovery from the Providence Center has stepped up, and they've done an amazing job.
The use of opioids has become somewhat prevalent, and strangely enough, it comes from, my knowledge of it comes from serving a couple of prosecutorial functions in my capacity as an attorney for the city of East Providence, as well as the town of Charlestown. And anecdotally, through students at North Kingstown High School, my son being one of them. The Rhode Island Medical Association approached me very early on in the planning stage of this session in an attempt to, I'll characterize it in my own way, to recruit new first responders. And those new first responders for opioid overdoses are the people who are there partying with them, or in some instances maybe delivered those drugs into the situation that has now turned potentially fatal. In the beginning of my career, I spent almost 10 years as an assistant attorney general, the last few as the deputy chief of the criminal division from 83 to 93. And I'm very familiar with the prosecutorial function at the felony level, particularly involving drugs. And there have been some opposition. There's been some opposition from law enforcement at the prosecutorial function, the Attorney General, to the idea, which is contained in a piece of legislation that I submitted, that anyone who calls 911 in an attempt to save a life, whether that life is saved or not, would be immune from prosecution for any direct or indirect criminal activity that took place surrounding the events that happened to cause this emergency to take place. There is a real balancing test going on as we speak in considering this legislation. It has been in place with reference to immunity for someone who possesses the drugs and calls 911, but it has not been in place. As a matter of fact, there is an active felony murder prosecution going on as we speak.
Generally speaking, in the literature, we see around 20 to 25% of drug users in multiple environments calling 911 in an instance of overdose. In the absence of a Good Samaritan law, Massachusetts now is actually looking at about 40-45% of their deaths or their overdose instances now actually indicate that they're getting a call to a 911 when they often those people would be found anyway, but that people would actively look for and call 911. I'm wondering what your thoughts are, especially with new advances in technology where we'll be able to text 911 as well, and how, I think by the end of this year actually, how can we increase access to, or encourage people to be seeking help, especially in the instances of our fentanyl-involved overdoses that are out there?
During all of our trainings, Tracy, we do encourage calling 911. I mean, with naloxone, even if the person is awoken, they need definitive medical care. I mean, this is what we say. You may have reversed the overdose, but the likelihood of re-overdosing, depending on how much opiate they had ingested, is very likely. Naloxone only lasts for 30 to 90 minutes, whereas an opiate stays in the body. If you overdose on methadone, let's say, that's 8 hours. Methadone will last for 8 hours, whereas naloxone only lasts for 30 to 90 minutes. So every training that we do, we encourage calling 911. We do mention the Good Sam law right now because it was in effect and saying, please encourage your friends and family to call 911. We encourage rescue breathing without naloxone and then call 911. We do talk about if you have to leave for whatever reason, call 911. Put the individual in rescue position so that they can breathe on their own if they do end up vomiting and the gurgling. But I mean, you've got to get this person to definitive medical care, and that's what we say. So even if you have naloxone and the person you give it to, they sit up, they start talking, the likelihood of re-overdosing still exists. Because remember, naloxone only lasts for 30 to 90 minutes. So having a Good Sam law encourages the calling of 911 and gets the person to definitive medical care, where they could be put into contact with a recovery coach, and then we start the cycle of, trying to get the person into recovery. So, I mean, I will be at the hearing tomorrow, because I am a firm believer that this Good Sam law has actually helped in in increasing access to naloxone, in terms of providing coverage to police, or providing coverage to school nurse teachers as we're looking down the line. If we're going to increase access to naloxone, we also have to increase access to immunity for the administration of naloxone, which is tied into this bill as well. So, I mean, you need to be able to call 911 without being afraid of prosecution, is my opinion.
Well, I agree with Representative Craven, and think that we have access to folks who are at risk in our treatment centers, and I know that we have required training on overdose, but I'm not sure that we have incorporated the need to call 911 and the Good Sam law into that training. So that could be something that we could do and make sure that people are aware, at least of the current Good Sam law, and go from there.
I was wondering what the symptoms are that they're about to overdose, or like how does that exactly
Sure.
happen?
So we want to talk about the physiology of overdose. Is that what we're looking at?
I guess so, and,
sure.
also, and what should the person on the scene be watching for,
Sure.
and then do in terms of an intervention?
Sure. So the way that we teach non-medical responders to recognize an opiate overdose is we say that it almost looks like they're struggling or breathing, struggling for breath. Almost like, we call it the nod. Their head will go down, and you'll hear gurgling sounds. We always try to yell, wake them up, shake them if they're not moving. You look around, assess the scene. Do you know if they took an opiate, or if there's a needle in their arm, or is there a needle somewhere else? The likelihood that they took or having an overdose is very high. We try to teach people to do the chest sternum rub right here. If this doesn't wake you up, there's probably something wrong. So this is where we tell people to call 911 to make the assumption that there is an opiate overdose here. Remember, it's always a respiratory issue. So what happens is the opiates go and they attach themselves to the receptors of the brain, and they tell the brain that, don't worry about breathing, I've got it. I got it. Relax, you just relax, I'm gonna take over breathing, but the body stops breathing. It's respiratory failure. So the individual, it's all respiratory, no cardiac. So the primary treatment for respiratory depression is oxygen, right? So we teach everybody, with or without naloxone, you give rescue breaths. 1 breath every 5 seconds. Tilt head back, chin, rescue breaths. Okay, so if this is an individual that you know, that you love, and you do not have a mask, go for it. We always say if you have a rescue mask, use your breathing mask, obviously for public health issues. If you have naloxone, administer it. Call 911. Again, 30 to 90 minutes is how long naloxone lasts, which is why the individual needs to get to definitive medical care. They can re-overdose. Opiates last in the system for 6 to 8 hours. So again, naloxone only lasts 30 to 90 minutes. Again, the person will re-overdose by not breathing, gurgling, fighting for breath, unable to be awoken. We tell people not to mix opiates in order for prevention. No mixing. Do not take alcohol and opiates. That increases your likelihood of overdosing. Decreased tolerance increases a person's likelihood to overdose, meaning they've been either in prison or in treatment for 30 to 90 days. Their tolerance level for the drug, which they took before, let's say before they went into treatment, they took 8 Percocets, and that's where they got high. Then they go into treatment for 90 days. Their tolerance goes back to that base level. Prior to, I mean, it happens almost 24 hours after you've taken an opiate. Your tolerance goes back to that base level. Where taking 8 now is going to harm you rather than get you to the area where you were high before. So increased tolerance increases your likelihood of opiate overdose and mixing. So do not mix is what we say. And if you're already not well, if you already have trouble breathing, if you have COPD, if you have HIV, if you have pneumonia, if you already have a respiratory issue and you take opiates, it's going to increase your likelihood of overdosing because you're already struggling for breath. So please remember, opiate overdose is characterized by respiratory depressions. Yes, sir.
There are funding mechanisms, but they are usually available individually, like myself or yourself, Representative, through the legislative grant process to get a local grant for, in my case I did, get a $3,000 grant for the North Kingstown Coalition Drug and Alcohol Prevention Group, which go into the schools. And as a matter of fact, last week I attended, on the other end of the spectrum, at the Community Senior Center. It was a drop-off for drugs, prescription drugs that are no longer being used, basically to obtain as many opiates as possible that are available, to make them unavailable, and then to teach kids at the beginning of life cycle these are bad choices.
Well, I think in terms of the history of dependence or history of substance use, that's where screening at primary care really comes into play, and that's where we need to look more, because you think someone, if they're 65 years old and they have pain, you might not necessarily think does this person have a history of substance use disorders that I need to look at and see whether or not it's really safe to give them this prescription, as opposed to, let me give them a prescription and help them with their pain. So the more we educate physicians, and I'm really looking forward to the training that we're having on June 6th, with looking at safe prescribing for chronic pain and involving a screening for past history of substance use disorders or risk for substance use disorders or substance misuse. It gets missed. It's tough to do. I think that there's a lot of pressure in primary care settings to see people and see them quickly but meet their needs efficiently, and oftentimes things that will take time and take a little bit more effort to look and dig deeper is sometimes missed. So we need to get the word out there, the use of the PDMP, the use of the tools, and giving physicians not only saying you should do this, but how can you do this is really important, because not everyone is skilled at talking to people about histories of substance use. It's a difficult topic, so we need to be able to give people the tools to do that effectively.
Are there alternatives to pain medication, opioid analgesics for pain that could be offered for this population?
Well, it's not my area necessarily of expertise. You think of things, and I know that we had this effort, the communities of care, that looked at use of massage, acupuncture, other things that were helpful in terms of relieving pain. I'm not sure, I haven't looked at the studies of how effective they are versus opiate medication, but I think there are alternatives. They're just not as quick and easy as what we as the American public have come to expect in terms of relief, and we see that advertised all the time, is that if you have this problem, take this pill. If you have this problem, take this pill. And what we come to expect as a culture is that every ailment that we have will immediately be resolved by taking some kind of medication.